Hi, everybody. Very welcome to today's webinar from the series Tuesday Lunch with Rita. This was organized in collaboration with EUVAS, the European Vasculitis Society. I am Sara Monti. I'm a rheumatologist at the University of Pavia in Italy. My co-chair here today with me is Maria Cid, a distinguished expert in vasculitis who is a consultant at the Department of Autoimmune Diseases Hospital Clinic, Barcelona, Spain. And our speaker is Benjamin Terrier from the Internal Medicine Department at the Cochin Hospital in Paris, France, who is a great and renowned expert on ANCA-associated vasculitis and vasculitis in general. Benjamin will give us a talk and overview on the management of these diseases in today's talk, which is how I treat AAV. Thank you very much for being here. We look forward to hearing your presentation, and we're very happy to have you here. In case the audience has any question, please type them in the question section and we will discuss them at the end.
Thanks a lot, Sarah and Maria, for the invitation and to the RITA ERN network. I'm very pleased to talk about the treatment of ANCA-associated vasculitis. So let's go. So you can find here some of my disclosures that will be related in some cases of the drugs that we'll discuss. So very briefly, before really moving to the therapeutic management of this disease, I just would like to remind that ANCA-associated vasculitis are small vessel vasculitis, which are systemic necrotizing vasculitis associated with the presence of ANCA, which are anti-neutrophil cytoplasm antibody. So it's a group of 3 diseases, which include GPA, granulomatosis with polyangiitis, MPA, microscopic polyangiitis, and EGPA, eosinophilic granulomatosis with polyangiitis. The 3 main organs involved in this group of disease are the kidney, the lungs, and the ear, throat, and the ear, nose, and throat areas. And as you can see, the specificity of the ANCA can be different according to the phenotype of the disease, but they are more targeting the myeloperoxidase in microscopic polyangiitis or the protein 3 in GPA. So if we move to the treatment of this disease, I decided today to focus on 5 main questions on the treatment of this disease, which focus either on the first part, which is what we call the induction phase, and then the second phase, which is the maintenance phase. So we could discuss about other questions if you have at the end of the talk, but I think that one first question is, once the diagnosis is made, what should be the induction therapy, and especially should it be cyclophosphamide or rituximab? So the main regimens that are used for induction, if you go back to the literature, is mainly rituximab alone in combination with glucocorticoids, and the approved dose was what we sometimes call the hematological dose, which is for infusion of 375 milligrams per meter square. But the use of what we sometimes call the rheumatoid arthritis regimen, which is 1 gram 2 weeks apart, could be used even if the level of evidence is lower. And probably that the main limitations are that it is not validated in very severe patients according to the pivotal studies that was published more than 10 years ago. And sometimes it is described widely that there is a delayed response to therapy, which is frequently considered to be around 6 weeks. The other major treatment is cyclophosphamide, that is mainly used in Europe intravenous rather than oral, and it's usually a regimen of 6 infusions. And what is one important point is that it's the standard of care in very severe patients because the treatment is considered to be more quickly effective, usually maybe around 2 weeks to 4 weeks, but there is more limitation, especially according to the fertility and the long-term side effects. And more, the question of combination therapy of rituximab plus cyclophosphamide are sometimes discussed, maybe to use less steroids. And the advantage of that is to combine cyclophosphamide, which will be more rapidly effective than rituximab alone. But we could discuss about the long-term effect, especially about the risk of infection. But this regimen was validated in severe patients based on a study 10 years ago in the New England Journal of Medicine. So what does the recommendation says? If we go to the category recommendation, which is the kidney disease recommendation, you can see that for a newly diagnosed diagnosis of AAV, it is recommended to combine the glucocorticoids with either cyclophosphamide or rituximab. And as I told you before, in the very severe patient, especially the patient with renal disease, cyclophosphamide is usually preferred because of the limited experience in this situation with rituximab, and because the patients from the pivotal study, the REF study, with markedly reduced renal function were excluded. So cyclophosphamide is usually preferred, but in this situation, the combination I was telling you of cyclophosphamide plus rituximab could be considered in some cases. If you go back to the category recommendation, you can see that mycophenolate mofetil is proposed in non-organ threatening involvement based on the data from the MY6 study. But you also remember that MMF is less effective than azathioprine to maintain the remission. That's why mycophenolate mofetil is sometimes discussed only in non-severe patients with MPO-ANCA, but in this situation, usually we preferentially use rituximab. So rituximab, in contrast, could be preferentially used, and it was we do in practice, in children, in patients for which there is concern about fertility, and also in patients with relapsing disease or positive PR3-ANCA. And these data are from the post-hoc analysis of the REF trial that showed that rituximab was not non-inferior to cyclophosphamide, but superior to cyclophosphamide to induce the remission. So that's why in this situation of relapsing disease and positive PR3-ANCA, we usually prefer use rituximab. Very recently, an emulated trial from the data from the French vasculitis study group registry were made to compare the effectiveness of rituximab and cyclophosphamide in inducing GPA remission in a population that was not included in RCTs, but in unselected patients. So the primary outcome was the remission rate at 6 months, defined as the BVAS of 0 and a prednisone dose lower than 10 milligrams per day. And as you can see, the primary outcome in this population of GPA exclusively was better with rituximab compared to cyclophosphamide. And similar results were observed when we analyzed especially the newly diagnosed GPA and not the relapsing one, the patients with MPO-ANCA GPA, which is a small part, but it sometimes occurred, and in patients with a more recent treatment during the last 5 years of treatment. So because of that, in fact, we will preferentially use rituximab in all GPA patients and not only in PR3-ANCA patients. What does the recommendation from the EULAR that will be very soon released in Annals of the Rheumatic Disease, and you can see Maria also in this group, is clearly that for remission induction in patients with new onset or relapsing GPA-MPA with organ of life-threatening disease, it is recommended to use a combination of glucocorticoids and either rituximab or cyclophosphamide. You can see that Rituximab is indicated to be preferred for relapsing disease. In the EULAR recommendation, there is no statement about GPA or PR3, but it is the way I treat and we treat in our center GPA, especially with the preferential use of rituximab. In patients with a non-life-threatening disease, you can see that it is recommended to use a combination of glucocorticoids and rituximab. And in this population, and just to go back to what the CADIGO recommendation were stating, that methotrexate or mycophenolate mofetil could be used as alternatives to rituximab, but clearly rituximab in this population is preferentially used. Another important question is about the glucocorticoid regimen. What dose of glucocorticoid should we use at the induction phase of the treatment? Is it the standard dose or the reduced dose? Clearly, what was a major step to move forward on that was the PEXIVA study, which is the largest study conducted so far in AAV, which included more than 700 patients with severe ANCA-associated vasculitis, only GPA or MPA. And you can see that severe AAV were defined as a renal failure with an estimated glomerular filtration rate lower than 50 milliliters per minute. 20% of these patients were requiring dialysis and or alveolar hemorrhage, but only less than 10% at severe alveolar hemorrhage. And the primary outpoint was a very tough primary outpoint because it was a composite criteria of death and or end-stage kidney disease. So you can see that there was two questions in these trials, either the place of the plasma exchange, and after that there was a second recommendation about the comparison of standard dose of steroids and a reduced dose of steroids. You can see here with the dashed line the reduced dose during follow-up in comparison to the standard dose, and you have in the table the major steps. So you see that for a patient, for instance, of 60 kilograms, the treatment will be initiated at 60 milligrams per day of prednisone. At 5 to 6 weeks, there will be 20 milligrams per day, and at 3 months, 10 milligrams per day. And the dose of 5 milligrams per day will be reached at 4 months. So it's a very quickly tapering of glucocorticoids, and so this regimen was evaluated. And as you can see, the reduced dose regimen was non-inferior to the standard dose in this population of severe AAV, and based on this tough criteria, which is the primary, the composite criteria of death and or end-stage kidney disease. So far, it does not provide some information about less tough criteria like the occurrence of minor or major relapse. It was very important also to show that the use of the reduced dose was associated with a decreased rate of serious infection at 1 year with a reduction of 31%. And as a reminder, serious infection is the first cause of death during the first year in AAV. This data about the reduction of the steroid dose were also supported by the LOVA study, which was a Japanese study, post-approval study after the approval of rituximab, only in MPO ANCA patients with no severe disease, renal severe disease, but these patients had eGFR higher than 15 milliliter per minute. So it was still some severe patients with renal disease, and the patients were randomized to receive either a reduced dose of steroids, twice lower the dose, or a standard dose. And the primary endpoint was this time not a very tough criteria like death and or end-stage kidney disease, but a remission rate, which was without any steroids at 6 months. And you can see it was lower than 10 milligrams per day. And so as you can see, once again, there was a non-inferiority of the reduced dose compared to the standard dose. There was also a reduction in severe adverse event, and especially serious infections, suggesting that the use of lower dose is very important. So that's why that a new recommendation from the EULA recommendations that will be released very soon, as the paper is accepted in Annals of the Rheumatic Disease. The group recommended as part of the regimens for inducing remission, the recommendation of oral glucocorticoids starting at a dose of 50 to 75 milligrams per day, depending on the body weight, and with a rapid reduction, which is the same reduction as proposed in the PEXIVA study. So it's a major step forward because now the European, the US recommendation, or the recommendation goes to the dramatic reduction of glucocorticoids. The question is about also, could we use the glucocorticoid reduced dose regimen in all situations? And I can say that I have personally some concern about using this reduced dose in some situation. Of course, the situation is not included in the PEXIVA trial, but it's something that is true in all for all studies. The regimen, using this regimen without any pulses of methylprednisolone, because it was mandatory to do that in the PEXIVA study. The use of this regimen without any immunosuppressive agents, because the PEXIVA trial was made like that. And also when the use of rituximab was preferred as an induction therapy over cyclophosphamide. And if you move to the supplementary tables in the New England Journal of Medicine paper of PEXIVAS, you can see on the last line that rituximab, that was only used in 15% of the patients in the PEXIVA study, where there was a tendency in favor of the standard glucocorticoids regimen over the reduced dose in the patients receiving rituximab. So it was not statistically significant, but as you can see with the confidence interval, it was dramatically moving in favor of the standard dose. So I think you just have to be aware of that to monitor your patients. The next question is the question of the plasma exchange. You know that since the publication of PEXIVAS, there is a lot of discussion about the place of plasma exchange to induce the remission of the patients. If we move back to the first question in the PEXIVA study, it aimed to evaluate adjunctive plasma exchange on top of standard of care in these patients. As you can see here, the cumulative incidence of the primary outcome, which was death or end-stage kidney disease, was similar between the two groups. So plasma exchange was not superior compared to no plasma exchange for this criteria. And as you can see, at 1 year, there was maybe a tendency in favor of plasma exchange, but it was not significant. So based on that, almost everybody was convinced that plasma exchange should be ruled out of the initial therapeutic management, even if in very severe patients, and especially the patients with more than 500 micromole per liters of serum creatinine or requiring dialysis, there was still a question because of the results of the MEPEX study 15 years before. So the authors of the PEXIVAS trials made meta-analysis of the studies evaluating plasma exchange, which included 9 studies, roughly 1,000 patients. But what is probably a limitation is that first, PEXIVAS was representing roughly 70% of all the study population, which is highly asymmetric in the proportion of each study. And as you maybe see, the first study included in this meta-analysis were between 1980 and 1990, So it was study performed more than 30 years ago. So the technique of plasma exchange dramatically changes. And so I think it's complicated to mix apples and oranges, you know, when you're dealing with this type of techniques. But what we can say that in this meta-analysis, the rate of end-stage kidney disease at 12 months was significantly lower in the plasma exchange group. And so that's why this group of experts considered that in patients with moderate to high risk of end-stage kidney disease, and in fact, patients with a serum creatinine at baseline greater than 300 micromole per liter, there was a weak recommendation in favor of plasma exchange, but they also stated that there was a weak recommendation against the plasma exchange in patients with severe alveolar hemorrhage. What was the recommendation of the CADIGO before this meta-analysis? You see that in the CADIGO recommendation, knowing the results of the PEXIVAS trials, they were still maintaining the fact to consider plasma exchange in patients with very severe renal disease, and especially the patients that met the inclusion criteria of the MEPEC study, more than 500 micromole per liter and or requiring renal replacement therapy. And they were also considering plasma exchange in patients with severe diffuse alveolar hemorrhage. And of course, also in patients with an overlapping disease of ANCA and anti-GBM disease. What do the EULAR recommendation proposed? They extended the indication of plasma exchange that should be considered in patients with serum creatinine greater than 300 micromole per liter due to active GNRP. But the routine use of plasma exchange for severe alveolar hemorrhage was not recommended. So this second point is probably a very challenging and controversial point because in fact we're lacking data. You know from the PEXIVAS study that only 9% of the patients had severe alveolar hemorrhage, and so it's very complicated to make statements and recommendations with a so small population of patients. Recently, at the American College of Rheumatology, the role of plasma exchange in patients with severe alveolar hemorrhage was discussed. And as you can see, 27% of the patients from the PEXIVAS trial had a diffuse alveolar hemorrhage, but only 60 patients had severe alveolar hemorrhage, which was defined as the requirement for mechanical ventilation or a blood oxygen saturation lower than 85% on room air. You can see here, and especially on the graph on the right side, that the green line is the 1-year overall survival in patients with severe diffuse alveolar hemorrhage with a nasal ratio of 5, indicating that the risk of death is multiplied by 5, which is a very important risk of death. So based on that, we, maybe not everybody, but consider that these patients require something more than the standard of care. Also, if you analyze what was the data presented at the SCR, the overall survival at 1 year of patients with severe diffuse alveolar hemorrhage treated with PLEX and the patient with severe diffuse alveolar hemorrhage not treated with PLEX, you can see that there is roughly a 10% difference, which was not significant, but the population was really small. But in my opinion, it really raised the question about considering that severe diffuse alveolar hemorrhage could be an indication for PLEX, and rather that recommending that it's a recommendation against PLEX. So the next question, once the remission is achieved, is the maintenance therapy. And probably not what is the optimal drug, because rituximab is now clearly demonstrated to be the best treatment to maintain remission, but what could be the optimal rituximab regimen? So you know that the risk of relapse, it's important in ANCA-associated vasculitis. If you look at the data from large randomized control trials, all published in the New England Journal of Medicine, Cicazarem, Vegant, RAVE, the risk of relapse at 18 months or 10 years was quite important, and there is a prognostic interest of the PR3 ANCA specificity, because in almost all the cohorts or the prospective randomized trials, patients with PR3 ANCA have a poorer relapse-free survival than patients with MPO ANCA. So the question of the optimal regimen of rituximab is a question, and since roughly 5 years in the US and more recently in Europe, rituximab was approved to maintain the remission based on the data from the French Menritsen trials that was published in 2014 in the New England Journal of Medicine. And with the reduction of the risk of relapse in comparison with avacopan, that was roughly a 5-fold reduction in the risk of relapse. So based on this risk of relapse and this very important risk of relapse in patients with PR3 ANCA, we proposed within the French vasculitis study group, but it was an expert proposal, maybe different duration of rituximab maintenance according to the type of ANCA, and especially to consider in patients with MPO ANCA or no ANCA that the regimen used in Menritsen, so a 2 years regimen of rituximab every 6 months would be appropriate. But in patients with PR3 ANCA, because the long-term follow-up of patients with from Menritsen 1 demonstrated a risk of late relapse in patients with PR3 ANCA, we recommended a 4 years regimen of rituximab, especially because of data from Menritsen 3 that showed that pursuing rituximab for 4 years instead of 2 years was not associated with more side effects. So we recently presented at the American College of Rheumatology and the ANCA workshop the pooled analysis from the 3 Menritsen trials, Menritsen 1, 2, and 3, that allow the comparison, as you can see, of 4 regimens. There is, of course, azathioprine, which was the older standard of care, but we also were able to compare the fixed rituximab regimen from Menritsen 1, which was 18 months of treatment. And so with the long-lasting effect of rituximab, we could consider that it was a 2 years regimen. There was an individually tailored regimen for of rituximab for 18 months that was a group from Menritsen 2 study, and it's in blue. And there was also the group of patients from Menritsen 3 that were randomized to pursue rituximab for longer time, and so it was considered to be the gray group, so rituximab 36 months. And you can see that after adjustment on the characteristics of the patients in the different trials, the major relapse-free survival was quite similar between the fixed rituximab 18 months and the rituximab 36-month regimen, raising the question maybe about reconsidering the optimal duration of rituximab, 18 months, maybe more than 36 months, or to evaluate a prediction model to identify which patient will be the more at risk of relapse, to maybe extend the treatment only in patients that will require that. So what is the recommendation of the EULAR? We recommend that treatment to maintain remission be continued for 2 to 4 years after induction. So you can see that the door is left open. But for instance, if I can say, how I treat ANCA-associated vasculitis, I do like we proposed within the French vasculitis study group, but it's a summary that will probably change in the future, and a longer duration could be considered case by case in patients with very high risk of relapse. So the last point I wanted to discuss is the emerging role for Avacopan. So you know that Avacopan is a drug targeting the C5a receptor 1, because from the data from the preclinical models in the mice, the major contribution of the C5a receptor 1 axis was demonstrated, and this drug that was initially called the CCX168 was shown to improve the involvement in preclinical models. So a phase 2, two phase 2, then a phase 3 were conducted, and the phase 3 was published 2 years ago in the New England Journal of Medicine. It's the Advocate study, and so it evaluated Avacopan plus Rituximab or cyclophosphamide versus glucocorticoids plus cyclophosphamide or Rituximab. So Avacopan was not evaluated on top of prednisone and standard of care, but it was replacing prednisone in this study, which were quite common GPA and MPA patients with not very severe disease. Two important points. In this study, if Rituximab was used as an induction therapy, you were not able to do Rituximab to maintain remission at 6 months and 12 months and so on, but after the study was completed. And also, I told you what is the recommended regimen for glucocorticoids, and it was not the comparator for Avacopan, because the total duration of glucocorticoids in the control group of Advocate was 20 weeks of glucocorticoids. So it's two limitations that should be included. You can see here what was the cumulative dose of prednisone in each group. You can see that in the Avacopan group, there was some prednisone prescribed, especially during the first months, and in gray, in the prednisone dose, so you can see that after 20 weeks, there is almost no difference in exposure to glucocorticoids, but the Avacopan group was still receiving until 52 weeks of Avacopan. And to make a long story short, there was a non-inferiority for the achievement of remission at 26 weeks in the Avacopan group compared to the prednisone group. And if we consider the sustained remission until 52 weeks, there was a non-inferiority for Avacopan compared to prednisone, but also a superiority of Avacopan compared to prednisone. But at 52 weeks, as I told you, it was more an Avacopan versus no steroids, since there was almost no steroids in the prednisone dose. There was an interesting signal about the improvement of renal function at 52 weeks, because you can see that the renal recovery and so the improvement of eGFR was significantly better in the Avacopan group compared to the prednisone group. So the conclusion from the Advocate trial were that Avacopan was non-inferior to the reference regimen chosen in this study. I put that because, as I told you, it's not the recommended regimen for the US and the European recommendation. There is a reduction in cumulative glucocorticoid dose at 12 months. There is a reduced number of adverse events related to steroids, but no reduction of serious infections. There is an improvement of quality of life, and there is an improvement of renal recovery in comparison with the reference regimen chosen in this study. what could be the limitations to really maybe identify what will be the place of Avacopan. As I told you, the control arm is not the standard of care in 2023, and it could be a major difference, or it could be not. We don't know, but this study does not provide the answer. And there is no maintenance rituximab infusion at 6 months, at 12 months. And we know from the REV study in 12 years ago that if you do not do rituximab and you have no steroids during follow-up, and you do not repeat rituximab at month 6 and 12, you will relapse. I don't know what would have been the results if the patients were treated as recommended. The majority of the patients still receive glucocorticoids during the first months, and what would be a limitation would be probably the expected price of Avacopan, which is much more expensive than glucocorticoids. So what is the EULAR recommendation for Avacopan? You can see that it is stated that in combination with rituximab or cyclophosphamide, Avacopan may be considered for induction of remission as part of a strategy to substantially reduce exposure to glucocorticoids. And I think it's a good recommendation because it's really a recommendation based on the data and on, the feeling of experts. What are the thoughts we could have about the use of Avacopan? As you saw from the PEXIVAS study and the LOVA study, we know from this study that in patients in whom glucocorticoids are not contraindicated, the use of lower dose in combination with of cyclophosphamide or rituximab is possible, even without the need for new therapies. And I think it's something important is that we can use lower dose without using very expensive treatments. But in some cases, such as in patients with severe psychiatric illness or complicated diabetes mellitus, a totally glucocorticoid-free regimen is sometimes necessary, and Avacopan is a valid alternative to glucocorticoids in this situation. So what could be the indication for Avacopan in real life? We'll have to see and to find our best way to use Avacopan. As you can see with rituximab for maintenance, 10 years after the use of these treatments, we're still dealing with what is the optimal regimen for maintenance. So we need some time to really identify what would be the best regimen. But we can consider that it's preferentially used as second line in patients with adverse events related to glucocorticoids, and it could be in first line in patients with contraindication or at very high risk of glucocorticoids related adverse events. And there is some discussion about the renal improvement based on the results I told you. So what are the main take-home message I would like maybe to provide you on how we could treat ANCA-associated vasculitis is that rituximab should be preferentially used in relapsing disease, PR3 ANCA and GPA, and more cyclophosphamide in very severe patients. The optimal glucocorticoid regimen recommended worldwide now is the reduced dose regimen from the PEXIVAS study. The role of PLEX is still debated, and I think it's the beginning of a lot of discussion, even if it's already started. The optimal duration of rituximab has to be considered according to the risk of relapse between 2 to 4 years, and the role of Avacopan will have to be better defined when it will be available, and it clearly will depend on the price. So I would like to acknowledge all my colleagues from the French Vasculitis Study Group and you for your listening.
Thank you very much, Benjamin, for this excellent talk and this very to the point, very clear messages. So I hope it will be of great usefulness for the audience. So we had some questions already sent previously to us regarding the subject. Can you?
Yeah, thank you, Benjamin, for the great talk. One of the questions we received previously was regarding COVID in patients treated with rituximab, and the question is that patients receiving rituximab had a very low response on COVID vaccinations and a higher risk for the infection in these patients. So the question is, how can we balance giving the treatment that is the best for AAV patients, but keeping them safe from viruses like COVID?
Thank you for this important question. I hope that COVID will not be any more big issues, but it's still a little bit. So clearly, the Global Rheumatology Alliance clearly showed that rituximab was associated with higher severity of COVID-19. And there is plenty of study that showed that the achievement of a vaccine response with rituximab was dramatically low. So it was a double issue of rituximab. First, the severity of COVID-19 and the inability to be protected effectively. I think the response to this question could be quite different according to the place in the world you are, because the availability of monoclonal antibodies to prevent, so prophylactic monoclonal antibody to protect against COVID-19, and or the availability of Paxlovid, the treatment, the oral treatment for curative COVID-19, which is indicated in immunocompromised patients, is a key. Because, for instance, we were very lucky in France, and we were all these prophylactic monoclonal antibodies and the curative Paxlovid treatments were available. So we did not change at all our practice to maintain remission. We maintain the rituximab infusion as the optimal treatment to prevent relapse, because we were able to give to our patients the prophylactic monoclonal antibodies to prevent COVID, and in case of COVID, the treatment, the oral Paxlovid. But clearly, I totally understand that in countries in which the access to these drugs was not possible, some colleagues moved back to azathioprine rather than rituximab, and I think it was something that was, in my opinion, acceptable because it was the gold standard 10 years ago. But I think that if we get the access to all these drugs to get a prophylactic treatment or a curative treatment, I think that the use of rituximab to maintain remission is quite safe.
There is another question previously sent.
Yeah, the second question, you mentioned this already, but maybe we can talk a little bit further about this. It says that nowadays doctors try to get patients off steroids as soon as possible in order to avoid the side effects, and what would the use of Avacopan improve these side effects? And you mentioned about the serious infections, but what is your feeling about this?
So clearly, reducing steroids is now a very, very important point for everybody. But I think that probably that the question of using no steroids at all, you know, it's the same question in lupus. There is the believer in no steroids at all. There is the believers of maintaining 5. I think it's always very, you know, some question with a lot of discussion. I think that reducing glucocorticoids was a very important point, but I don't know if using no steroids at all should be, you know, the Graal, you know, the things to achieve, because using now the new Pexivas reduced dose regimen would maybe be associated with dramatically lower side effects related to that. And I think that if you combine this reduced regimen with rituximab, which is very effective to prevent relapse, with rituximab, we almost have no more relapse, even after stopping, discontinuing rituximab. In some patients, you can have relapse. So I think that we need probably more time to see, not based on our old patients who made many relapses, but with the new onset patients, if the use of this combination of low dose steroids and rituximab would not be clearly acceptable in terms of side effects. I don't think that 3 months of glucocorticoids like in reduced dose, then 5, is associated with so many side effects. And I think that the real contraindication of glucocorticoids that were required Avacopan are not so frequent, but it's very important to get this drug in the situation like that. But given the price, but we will have to see, for instance, in France, we don't know yet what will be the price. We know how it costs right now before negotiation, but it's 80,000 euros for 1 year in France right now. It will be lower, I think, at the end, but it's to show that it's an important point too. So that's why I think we will have to see, but the new regimen we have with low dose, I think will be probably acceptable, and the no steroids at all, I'm not especially fan of that. I'm especially fan of lowest side effects for patients, but will it be with low glucocorticoids or Avacopan or other treatment? In fact, I don't care. So that's why I think we need more time.
Thank you very much, Benjamin. We have a few other questions that were received. Maria, do you want to read a few of them?
We have a question from one patient that is very happy about all the concepts you deal with, but I would like to know a little bit better what non-inferiority means when you compare treatments.
So just very briefly, because that's true that maybe there is patience, and I'm sorry if I was not clear enough. So in randomized controlled trials, there is usually the type of trials in which you want to show that one treatment is better than another one. So it's a superiority study, and if it's positive, it will show that the new treatment is superior than the control treatment. It was the case, for instance, with rituximab as maintenance to maintain remission in MENRITSEN study, where rituximab was shown to be superior to azathioprine because the study was designed like that. And just for the patients, it's important to understand that the required number of participants in a trial is lower in superiority studies than in non-inferiority study. And for non-inferiority, which was the case for Avacopan, for instance, or the lower dose of glucocorticoids, is to show that my new regimen, the reduced dose of glucocorticoids, it's not better than the previous one, the standard dose, but I want to show that using lower treatments will be as effective as the control group. And so you have to do a non-inferiority study that will require more patients, but at the end, you will be able to say that the results are the same, but it's non-inferior. For instance, in a superiority study like MENRITSEN, if rituximab would have shown the same result as azathioprine, since it was a study to show the superiority of rituximab, it would have been a negative study, and you're not you cannot say that the treatment are similar. So that's why it's sometimes a difference that is important, especially for regulations, authorities, and when you are dealing with the approval of a new treatment.
Thank you very much. I don't see more questions in the chat. So let me ask you something about Avacopan. In the trial of Avacopan, patients were balanced for disease phenotype, GPA versus MPA. Patients were balanced according to ANCA specificity, but the trial included a lot of patients, I think it's about 80% of patients with renal involvement, whereas airways involvement were less represented. Maybe some real life experience are arising in meetings and maybe small short series. Do you have any information about how these patients with less typical presentation, with more airways disease, may respond to Avacopan? Or
so in a presentation, in a talk at the ANCA workshop, Peter Merkel presented the efficacy of Avacopan in the Advocate trial in patients with non-severe manifestations. So, you know, we could think about ENT involvement, airway disease, peripheral neuropathy, and the results that were presented were the same as with the more common manifestations. So far, the key message that are presented is that it will not be different, but especially in PS3 ANCA patients with pulmonary nodules, ENT manifestation, is Avacopan will be as effective as the standard of care for these manifestations. In my opinion, I really don't know, and I think we will need to get our own experience and to aggregate all our experience, because I think it's complicated to respond.
I have a comment. I actually think that you made an important point regarding the use of glucocorticosteroids. Most of the trials we have reduce glucocorticosteroids more quickly than the standard of care in order to demonstrate the efficacy of the investigational drug. But the reality is that many patients need more glucocorticosteroids. So we all agree that glucocorticosteroids need to be reduced, minimized. It is absolutely, we all agree. But sometimes this idea, what do you think? I think it has been too much promoted by patient associations, which in fact is understandable because patients don't like glucocorticosteroids. Also by pharma companies that want to underline, you know, the contribution of the new drugs, but probably, what do you think? Probably glucocorticosteroids still have a role in this disease. You mentioned that, and yeah.
No, I totally agree with you. You know, it's something that is always, we could clearly understand the patient point of view about glucocorticoids, but I think the major side effects were more related to the very high dose we were using for weeks or months, more than the continuation of 5 milligrams, even if on the bone, for instance, we could discuss. But so I think it's one important point, and I totally agree with you that sometimes the design that was proposed by pharma companies was taken into account, and that's why that especially for Avacopan, for instance, and it's really frequently something I have as a discussion with the pharma promoting Avacopan, is that the design was decided to stop the corticosteroids at 20 weeks and to do not do Rituximab at month 6 and 12. It was a choice, but now we are in a situation for which we do not know exactly what is the effect of Avacopan in comparison with the standard of care from the US recommendation and the EULAR. So clearly, it does not remove the fact that Avacopan, for instance, but it could be another drug, is important, but the role of the drug is complicated to evaluate, and I do not think that we should consider that removing all steroids is the major achievement. The major achievement is to get patients in good shape with an acceptable cost also for the society too, because we have to take into account everything. And so I think that using lower dose of steroids without new drugs, it's something that is probably also a good option.
I like it very much when you underline certain situations that where reducing glucocorticosteroids fast may not be possible, because these situations are a minority, but exist. And actually, we had some problems with patients referred because with, for instance, meningitis in GPA, where their glucocorticoids were rapidly reduced, and they had problems, and this is something that I think is important to keep in mind, that every patient may be different, and maybe what we need also is to identify predictors of response to be to stratify treatments to patient diversity.
Yeah,
So
and I think that
yes, go ahead.
For the reduced dose, in our experience, I don't know in yours, but clearly in patients treated with rituximab as induction, and especially those with serum creatinine at baseline greater than 300 micromole per liters, in these cases, reducing very fast using the reduced dose regimen of Pexivas in this group of patients was associated with a worsening of renal function at the beginning, and this outcome, which was maybe a minor relapse or a delayed response, was not, within the primary outcome criteria that was death and or end-stage kidney disease. And I think that the reduced dose regimen should probably be still the recommended regimen, but be aware that in some situation, it could be not really appropriate for this outcome, which is not a death or ESKD, but just the fact to control or not the disease.
We have another question in the chat that is, what's the maximum cumulative dose of rituximab? Are there adverse events related to long-term use of rituximab? Can you briefly comment on that?
No, there was data, I don't remember, it was from UK or another group, but showing that the cumulative dose of rituximab is significantly associated with the risk of severe infection. So clearly, I think that using initially 2 years of rituximab and or 4 years according to the patients, but maybe 2 years in a naive patients, which is in total something like 2 to 3 grams of rituximab, is probably acceptable, but after it will depend on the individual risk of relapse, because probably that giving more rituximab would be better to prevent remission than giving too many steroids because of relapses. So I think there is very case-by-case discussion, but I think that less you give rituximab, better it is, but I think you do what you can and what is the best for each patient, I think.
So time, unfortunately, goes, and we have to finish this interesting discussion. There is one comment regarding whether this talk will be available. This talk has been registered and will be available at the ERN-RITA website. So I would like, before closing the session, to announce the next webinar that will happen on April 4, and the title will be How I Diagnose Interstitial Lung Disease in Different Immune-Mediated Diseases. And this will be delivered by Claudia Bracaglia. So you probably will enjoy this seminar as well. So thank you very much, Benjamin. Thank you to my co-chair, Sara, And this has been really a very clear and very useful and nice seminar. And thank you very much again.
Thank you. Bye.
Bye-bye.
Bye.